العلم يحلو كلما كررته ولذاك عدت مكررا لحلاوته.
Go to us, actually usually we have some evidence, but most of our talks today will be more or less introductory. Other point actually I would like to thank Dr. Alqaha. He went actually bad health experience, actually he was in Stockholm and actually I informed him there, can you share us, and he was willing actually to share us with his presentation. He usually gives us 2 lectures. And just actually, he didn't supposed to join our hospital about 3 weeks ago. And then we discovered that he was hospitalized for 2 weeks there in Stockholm. And then he just came actually last week. So I would like just to thank him for my talk is about weaning. And as you see actually, if you go to search actually in the internet, PubMed about weaning, you will not actually see or encounter many literatures or many actually paper about weaning. And even the practice of weaning, you will see it also, it's some sort of controversy. When to start weaning, which baby you're going to wean him, this baby you're going to weight more than, if you have baby 500 grams actually, this baby actually did very well in first day of life in mechanical ventilation, CO2 40, and then the questions are going to extubate this baby. If you extubate this baby and he gets apnea actually in the same night, and then someone bag him, or actually some junior staff try to intubate and the intubate fail, and you know, like the intubation as I mentioned successful is actually stressful experience where it's no epinephrine, PDD, steroid release, blood pressures will go up and down, and this baby is vulnerable for intraventricular hemorrhage actually. Are you going to extubate this baby first day, or you wait, all the practice to wait for 7 days till you pass the stage of intracranial hemorrhage and then to try to extubate them? So that's why you'll see also a lot of controversy. It's actually, my talks will be about first definition, what the meaning of weaning, and then cause of weaning failures, and when and how to wean, and then some talk about what can help you to wean, and then some clinical trials of weaning. I found it dry, so that's why actually I get about like 5 or 7 cases of in our hospitals happening, so that's why we can share experience together. So it's simply, the definition of weaning is discontinuing of mechanical ventilations. Or actually the most appropriate definition is the process of slowly decreasing the amount of ventilatory support with the patient gradually assuming greater. So just take part from the machine and give it to the baby so the baby can go and you can extubate the baby. Why we need to wean the baby? Like this is a question. Why we did actually want to talk about wean? Why we need to wean the baby? Why we are actually in hurry to wean the baby and we ask our staff to wean? Cerebral palsy, and this is the most devastating result of our work actually, and we don't like to see it actually, was associated with prolonged mechanical ventilation, extreme low birth weight, who had normal early and late head ultrasound. So they did actually the baby who have normal head ultrasound. There is no IVH, there is no BVL, and actually you look for risk factor of cerebral palsy. What caused cerebral palsy for this group of patients? And we found very interesting study actually. For each 10 days they spend on mechanical ventilation, their incidence actually of cerebral palsy increased from 10 to 20%. In some study actually it's up to 30%. So each 10 days the baby stay on mechanical ventilation, his incidence, this is baby with normal head ultrasound. We don't talk about baby who have like IVH 3 or 4, or a baby actually who have periventricular recommenation. No, normal head ultrasound. And they found actually each 10 days 10 to 20% increase in incidence of cerebral palsy. More simpler actually, if we said each day the baby stay extra on mechanical ventilation, increase incidence of cerebral palsy by 1 to 2%. So each day the baby actually stay on mechanical ventilations, we are creating progress. Not only for the lung actually, but just for the brain and neurodevelopmental outcome. And the first people actually encounter these problems actually Philip, and remember the first definition for BBD, it came by Northway and Philip, and this is a group who have described the BBD, and they mentioned that oxygen plus pressure plus time is equal BBD. This is in 1975 actually. So long time ago we know that oxygen plus pressure, barotrauma, plus time. So times we can reduce the time by weaning. So this is all the 3 factors can contribute to bronchopulmonary dysplasia. Again, bronchopulmonary dysplasia is not also lung issue. Like this is not the baby who will first 2 years of life, he come to hospitalize, he may die from RSV. We have vaccinations, we can give them synergies, we can prevent RSV, we can educate the parent. But it's not only the lung, but it can affect neurodevelopmental health, isn't it? And there is very nice articles actually published by Barbara Schmidt. She looks for what risk factor can cause cerebral palsy. And she encountered actually many problems. She found actually BPD, bronchopulmonary dysplasia, increased the incidence of cerebral palsy by 22%. So BPD 22%. ROB, retinopathy of prematurity, actually needs treatment. It's increased by 22%. Abnormal head ultrasound, either IVH 3-4 or BVL, increased by 22%. So this is about 66% if you have baby with PPD, IVH, or abnormal head ultrasound and eye problems. And I will tell you something else. Normal baby, normal newborn baby, extremely low birth weight, who is actually like less than 1500 grams, who just graduated from NICU. You have normal head ultrasound, you have normal eye exam, you don't have BPD. You know what's the incidence of cerebral palsy in this group of patients? No, you have normal head ultrasound, you have normal eye exam, you don't have BPD. The 22%. And that's why she mentioned if the baby have, this is three groups, like we start from 22%, this is a normal baby. So if you have BPD, extra 22, so it will be 44. So if you have ROB, extra 22, so it will be about 67. So if you have another abnormal head ultrasound, another, so it will be 88% actually. So that's why we can manage this BPD by just reducing the times the baby stay on mechanical ventilation. And that's what we talk about. So this first case actually, as I mentioned, we collect this case from our hospital. This preterm baby, 26 week gestation, he's 20 hours old. He is in BSV. Yesterday we attend, I think your guy attends a lecture about the difference between BSV, assist control, and SIMV. He was on volume guarantee, 4 ml per kilo, 20/6. His eye time 0.5 seconds, FI2 25%. And this is his blood gas, his arterial blood gas. So the questions here, are you going to extubate this baby to CPAP? Are you going to give him a minofilm? Are you going to repeat the blood gas in 4 hours? Are you going to extubate to use a cannula? Or you use A and B? So first of all, this setting actually, like this baby, is this baby sick or not sick now? He is not sick, like he's minimal support, he's in BSV, his pressure support, like this is backup rate 20 breaths per minute actually. He didn't take it, like just the machine kept it in case if the baby gets apneic, it will support him. But actually the baby breathing by his own. Volume guarantee 4 ml. Do you remember yesterday we said the lowest volume guarantee we accept is 4 and maximum is 6. And this is, so his lowest volume guarantee you can give to him. His eye time 0.5 seconds, you know, like this is when we, like BSV, the eye times again is back up, just to avoid the side. But actually the baby depends completely on his eye time. So most of the time his eye time is 0.2 seconds, so he's not taking this eye time. Just to protect, to avoid the alarming of the machines, that's why we make it prolonged eye time, so we don't care about this. If I do 25%. And this is blood gas. Is acceptable blood gas for this baby or not? If you have baby 26 weeks, this is his lung actually, and 7.2, 46, PO2 55 by car 20 base excess minus 6. So this gas acceptable or not? Have baby 26 weeks. This is perfect gas for this baby. Actually, when we intubate the baby, like this is part of our protocol and part of our guideline actually, to carry the respiratory therapist to get you with a machine and the start to actually connect the baby to mechanical ventilation, you should have criteria for what saturation you're going to accept, what blood gas you're going to accept, what pH you will accept, and what CO2 you're going to accept. So for this baby, 26 weekers, what saturation will write for him? We need for them what's the acceptable saturation? 85 to 93. And this is recently actually the RDS guidelines of the aerobian done by Dr. Henry Halliday. He actually conclude, or from multiple meta-analysis, we are still waiting the COT or the Canadian oxygen trial. Still actually the result, inshallah, maybe come inshallah in October in December. So we are waiting the result of COT trial so we can know exactly what's the best saturation for this preterm baby. Till now we have problems with the best saturation. But till now we are going with 85 to 90 to 93 or 92. So this is acceptable saturation. What acceptable pH for this baby? We write actually 7.20 till 7.4. So it's acceptable. It's very good pH for this baby. CO2, how much we're going to accept for him? Yeah, 45 to 55. So this is our target, okay? And then, as I mentioned about saturation, blood pressure, so we write our parameter for the blood pressure. So this gas, for this baby, is perfect. Remember, you cannot get normal gas in this baby. This baby is preterm, it's very sick. If you would like to get normal gas for this baby, you will cough this lung actually. These lungs will be damaged, and at the end your baby, you cannot wean your baby. So that's why you should, this is the idea of permissive hypercapnia. And you cannot accept permissive hypercapnia without a dropping of your pH. Okay? I will tell you something else. You know what's the normal pH in utero for this baby? If we do core, or if we did scan pH for this baby in utero for 26 weekers, you know what's the normal pH? Yeah, 7.2 to 7.4. So just this baby 20 hours ago, he was in the same environment need. Plus he was hypoxic, but now he's hyperoxic, we cannot do anything for him. So this baby actually is ready for extubation. He is in minimal support, so he's taking breath by his own, so you don't have problems. So we will extubate him to CPAP, isn't it? Well, we mentioned about cerebral palsy, and we mentioned about each one day this baby stay in mechanical ventilation, increase the incidence of cerebral palsy by 1 to 2%. 10 days increase it from 10 to 20%. You don't like this baby to stay longer times on high frequency, on mechanical ventilations. I will give you another scenario. Someone will say, okay, this baby actually, there's a study shows about, if they extubate in first 24 hours, there is 30% possibility that could be re-intubated within 7 days. So this study actually done. So there is 30% possibility that this baby may be re-intubated within 7 days. But let's assume you extubate this baby, okay? Or you extubate 10 baby, and 3 of them re-intubated in first 7 days. You did good thing or bad? Because you saved 7 baby to be intubated, isn't it? So this is the idea of it. So here, I didn't guarantee 100% that this baby will never be re-intubated. Okay? But I have some evidence to support that there is possibility this baby, more than 50%, this baby can stay rest of his life in CPAP. So extubation, I think, is good move. Because the other question, repeat the blood gas after 4 hours. What you will gain after 4 hours if you repeat the blood gas? Nothing, isn't it? Lung is improved already. You give the surfactant, and the baby improved. You repeat, extubate to nasal cannula. Remember yesterday the lecture about CPAP and how CPAP splinting the airway, how CPAP decreases the apnea. So here, aminophyllin, or methylxanthine if you use caffeine. So here, what about aminophyllin? Yeah. So here you can extubate to CPAP and you can add with it aminophyllin. So you load with the baby with aminophyllin, so the answer will be E. So if you have this baby actually in first few hours, baby is doing well, load the baby with aminophyllin, start maintenance, extubate, put the baby on CPAP. This is actually about extubation failure. This is the cause of extubation failure. Look what's the most common cause of extubation failure? Apnea and the bradycardia. So that's why actually the choice of aminophyllin was a good choice. Because here the most common cause is apnea and bradycardia. Not the oxygen requirement, actually not the other surgery. Most like 60% nearly due to apnea and bradycardia. And you have medication which can help you to prevent apnea and bradycardia. Plus also CPAP actually can help you to prevent apnea and bradycardia. This is just, I think, because there is many concerns that this small baby, they need the tube to be stable. We take this actually baby from Dr. Summer's hand, so it's not my slide. But in his study and his unit, this baby was never intubated. This is in all the practice, they didn't try to extubate. This is 94. After 96, actually start to become more aggressive in extubation and use CPAP. And you see actually this baby never intubated, and we are talking about extreme low birth weight infant. And you can see actually 25% of the babies, they never needed tubes. So again, it's just like something about physiology. It's just like about balance actually. It's more balance between the load and the capacity. So this is the mechanical ventilation. The load, which is represented by elastic change of the lungs and resistive factors which affect the lung, plus the minute volumes. This is the load. The baby will need higher minute volume or minute ventilation. This presents load. And the capacity of the lungs, their respiratory drive, their muscular dysfunction, their neuromuscular disease, and part of this actually sedations again. If you use sedations as Dr. Morphine mentions, actually you will decrease actually their capacity. I mean, like the baby will be actually more apneic. They don't have the power actually to breathe out. So you're decreasing the capacity by giving more sedation. The respiratory rate actually it can cause by increased elastic load. Like if the baby still has lung disease, you have the baby, you admit the baby, you found actually the baby is oxygen requirement 21% the first few hours of life. So we think that this baby still, we don't need surfactant, so we wait for to bear the baby, but actually gradually the RDS is getting worse and he needs surfactant. Or he gets secondary pneumonia due to that, or he still have duct, unfortunately the baby have large duct and shunting the blood to the lung, so the lung is flooded, so this is that it will increase elastic load of the lungs. Or the baby have abdominal distensions, bagged too much, so the abdomen so distended and you didn't deflate it. Or you have hyperinflated lungs, and this is actually common sometimes. You admit the baby, our starting setting is usually 20/6, the baby have healthy lung, the mother receive antenatal steroid, so you start 6, the actually lung markedly distended, you see CO2 high, and then you start to escalate your setting, but actually the baby need to be weaned, and if you drop the baby little bit, the baby will be engaged. Again, resistive loads, like if the baby has secretions, and if the baby stay more longer on mechanical ventilation, he'll get more secretions, irritation from the intratracheal tubes. Or if you use a small size, like you have baby, like 1.2 kilo, and you put 2.5 tubes, and as Dr. Demrdash mentioned yesterday, it's actually the resistance will markedly increase 4 times according to the diameter of the 80 tubes. Or there is upper airway obstructions. This is another actual issue, very important, increased minute ventilations. We always say just before you extubate the baby, calculate the minute ventilation of the baby. Just see how much the baby actually. Because sometimes the baby gives you good gas. You have 7.2, you have CO2 45, but the baby breathing by 100 breaths per minute. So actually the baby is working like horse just to give you this good gas. Also you put him in minimal setting, you put him BSV, but he tried to compensate for you to give. If you take this tube from this baby, actually within 1 or 2 hours this baby will fall. So to calculate minute ventilation actually is very important, and actually can cause by simple things like pain and irritability. You don't need to give sedation. You actually have good nursing staff, you can just swaddle the baby or cuddle the baby, and you can manage using pain medication. Sepsis sometimes cause with the baby hyperthermic, like the temperature when 38 or something, he will be tachypnic to compensate. So if you extubate him, this baby will fall into, or have metabolic acidosis for other reasons. This is another case actually. This is 27-week gestation, 2 days old, and he's breathing by 80 to 100 breaths per minute. He was an assist control. His rate 35, volume 94 ml per kilo. His I times 0.35, and this for actually 20/6. FiO2 40%. It's actually more or less the same blood gas, 7.2, 46, VO2 40, bicarb 17, this X is minus 10. Here you can see the X-rays. So yeah, it's good. So this baby, what about the ventilator sitting here? Okay, this is minimum, isn't it? He's a rate 35. It's taking 20/6. Like we like beep in our unit. Like we love open lung structure. Like nearly all our baby in beep 6 or 5. But as I mentioned yesterday, just be sure about your flow, because the flow in the machine can trick you. If you use higher flow 8 and you have the same setting, it can hyperinflate the lung. So be careful about real-throw. This is very important. And this is the practice happen actually. That's why some units they use actually low beep. But the problem is they use higher flow. And this is more dangerous actually. So maximum of your flow actually on conventional ventilator should be 7. Okay? So that's why just be cautious about this. So that's why we adjust our flow to 6. At the same time we use the beep 6. Most of our baby will see in beep 6, 5. Very, very rare actually we go less than this. I times, it's very good I time for the baby, isn't it? So baby in nearly minimal setting, 5 to 40%. We give you more or less acceptable gas. I like these questions. Why you would like to extubate that? Excellent. So the trick here actually. So this baby, if you look for 100 multiplied by 4, so this baby is his minute ventilation is about 400, isn't it? So it's too much actually. So here this baby working hard. This baby have metabolic acidosis. So also 7.2, but 7.2 there's problems to push this pH down if the metabolic acidosis not respiratory. So this baby have problems. Once this baby, preterm baby in second day of life, what problems you suspect this baby will have? Second day of life you have preterm, 26, 25, 27 weeker. In second day of life, what's in your mind actually before you go and examine the baby? Yeah. So here, if you extubate this baby to CPAP, I will guarantee that he will fail. Okay? Even if you give a minofiller. Because this is not the issue of apnea. The issue here is lung actually flooded. It's congested lung. And this baby actually cannot cope with BDA. So this is the typical hemodynamically significant BDA. You know, like the argument now about to treat or not to treat the duct is if it is hemosignificant, beta and ductus arteriosus, then you need to treat. Not hemosignificant, then you cannot. But this actually he pushed the base excess down. This baby he was actually inotrope also. He was hypotension. He was tachycardic. So to extubate, to give a minofiller is not, to repeat the blood gas will not change the smell. So the only option is, yeah, and this is the echo. This you can see actually the duct, how much actually, and it all reversed. You know, the red color is directed to the heart. So it's actually shunting actually from left toward the right, so the lung actually flooded. So after we treat the baby, actually we can extubate this baby. So decrease the respiratory capacity. If you use sedations, if the baby have problems, CNS infection, you admit baby, the mom's GPS, and it's not fully treated, and actually the baby is continuous sick, it continues to be sick. You didn't realize that this mom's GPS, this baby is sick, you don't use the energetic dose, so this can happen. If the baby has periventricular hemorrhage, or has periventricular leukomalacia, or the baby has hypocapnia, actually you're washing CO2. I will like, you cannot actually extubate baby and his CO2 is 25. So just please wean the setting till CO2 come in acceptable level, and then you can wean the baby. Muscular dysfunction actually, and like if the baby has some muscle problems or weakness, and as Atif mentioned, actually malnutrition is very important issue actually. A preterm baby actually, they can actually go in very bad catabolism if they stay 1 day without protein. And that's why actually most of the unit now, they start to have what they call it vanilla solutions, like just protein in fluid, 50 ml, we keep it in the unit. So immediately after the baby delivered, you hang the protein. So this baby, he's taking protein from his mom about 4 grams per kilograms. In utero, he's taking, so immediately we clamp the cord and we start to give him detail. So he will start to catabolize his own proteins. And you're talking about baby actually 25, 26 grams, so it's very tiny. So if you didn't take care of the nutrition, actually this baby gradually will get weak, and actually you cannot extubate this baby. If you have electrolyte disturbance, of course, and if you have hyperventilations. Neuromuscular problems like diaphragmatic dysfunctions or prolonged neuromuscular problems. Actually, there is other very important actually. It can actually, if you use aminoglycoside and phenobarb actually, it can affect the baby, okay? It can cause muscle weakness for the baby. So that's why be careful about using the medication. So sometimes the baby is healthy but just combination of the medication. If you use aminoglycoside actually with muscle relaxant, isn't it? This will prolong the actions of muscle relaxant and it will deteriorate the baby. So you stop the muscle relaxant yesterday, but because you plan to give aminoglycoside for 7 days, the baby still have weak and you cannot extubate the baby. This is another case actually. 28 weeker, 2 days old, using assist control 50, volume guarantee 4 ml, 20/6, I time 0.35, FI2 40%, and this is the blood gas. 7.2, CO2 64, BO2 50, bicarb 25, base excess minus 2.7. Yeah, so this is again, that's what we always tell our staff. Please, actually, if they tell you about the blood gas, don't take action with the blood gas. Okay? Just go and assist the baby. So here, 7.264, he's high CO2. So what action you will do is a rate 50 or volume guarantee 4. So what he will do, either he will increase the volume guarantee to 4.5 or he will increase the rate to 60, isn't it? To wash the CO2, because CO2 is high. But actually, if he assists the baby and examines the baby, actually, or he did X-ray, he can see this disaster actually. So the action is just to put the attitude. Just actually we put this scenario because many times actually you see the baby either wean or the baby actually escalating the setting overnight without actually clinical exam. We miss this part completely. Now always actually when we teach, like when you ask one of our residents in the round in the mornings, actually this baby, what this baby have metabolic acidosis, you'll ask you, I will call the cardiologist to do echo. But you didn't examine the baby. We don't do chest X-ray now, we don't do ECG, we just run for the echo. So this is the problem actually, exactly the same. Here you have blood gas, you have saturations, actually you have setting, so immediately what you will do, you will escalate the settings and then the air. Actually the baby will have pneumothorax here and will collapse here and the baby deteriorate. So again, to just go and clinically examine the baby is very important. You remember Dr. Demerdash's presentation yesterday, I have one very nice slide about the patient actually lying here, and this guy here looking for the ventilator, and this guy here looking for the monitor, and the other 2 guys looking for the EEG, and no one looking from the 4 staff around the baby looking for the patient. So each one is looking for his machines. Or the expression actually, what they use is commonly in North America actually, they say they fly with monitors. So how is the aeroplane fly? How is the aeroplane travel? According to the monitor. So why we manage our patient by monitor? But each time actually we do it, we get burned. You see sometimes in second day you have disasters happening. So always go and examine and assess your baby. How to wean actually? You should look for the clinically and metabolically stable baby. So we cannot extubate baby actually. He's clinically okay and metabolically abnormal. Like you sometimes actually baby have severe metabolic alkalosis because of urea cycle defect. So that's why this baby can fail. If FiO2 is than 40%, this is acceptable weaning. If you have actually effective spontaneous respiratory drive, so that's why we said yesterday, if you remember the lectures, don't extubate directly from assist control mode. Just like try other mode, like so where you can challenge the baby, SIMV mode or PSV mode. PSV mode, just give the baby little bit low rate, like 20 or 15, allow the baby to take his own breath, just see a few hours, feels okay, then you can extubate the baby. And if you have satisfactory blood gas, This should be done at low rate if it is less than 20 breaths per minute, and low PIP 10 to 12 actually if the baby less than 1 kilo, and 12 to 15 if the baby more than 1 kilo. This part actually of the low rate and low PIP, it's not evidence-based medicine. Yeah, just like I'm telling you, it's not a rule. I take it actually from Stephen Dunn. He have very nice actually paper about weaning from the mechanical ventilation. He put it just as guideline in his unit, but there is no evidence-based medicine. There is no study done to compare which PIP you're going to extubate or which volume guarantee you're going to extubate. So for oxygenations, if you'd like to wean, start with FiO2 and then go to MAP. If you use high frequency, MAP would be easy. If you don't use them, P or I times or PIP. Decrease FiO2 less than 40%, FiO2 more than 40%. Some trick can help you to maintain hemoglobin more than 15 grams. Avoid flip-flop during the change. Like don't you have baby, have CO2 40 and even assist control 50. Immediately you shift the baby to BSV. No, just gradually wean the baby, like just decrease rate by 10 and see what's the effect of this 10 on his baby. So for ventilation part is which is responsible in CO2. Remember our talk yesterday about high frequency. You should always calculate minute ventilation as we mentioned, which is simply either volumes multiplied by rate, and actually in the same times what you need it to be between 240 or 250 and 360. It shouldn't be like 400 as the scenario we give early. It shouldn't be 500. And at the same time, it shouldn't be less than 240. Like, so you cannot extubate baby whose minute ventilation is 140, 150. Even if he is like CO2, you allow permissive hypercapnia. Because this baby, he went to apnea. Because he is breathing very actually low rate. You accept higher CO2, so you're going to extubate the baby, but the baby is actually apnea. He cannot take his normal minute ventilations. If you use volume guarantee, I don't know if someone using volume guarantee here on the Draeger. Do you use volume guarantee here? Okay. So if you use volume guarantee, remember yesterday we talked about the evidence to support using volume guarantee. We said it's increase the incidence of pneumothorax, increase the incidence of BVL, increase the incidence of neurodevelopmental outcome. And this is meta-analysis. So this is meta-analysis. So we have enough evidence to support using a volume guarantee. But the problem actually is the sensor. This is a problem. So always you encounter a problem with the sensor. Again, don't use low rate. If the baby he needs the rate less than 20, definitely don't need the tube. How to wean? Decrease the most potentially harmful parameter first. Yesterday we talked about lung injury, and we said what's the most harmful trauma to the lung? Volutrauma, yeah, we said, and we presented yesterday the study which shows that when they ventilate the baby with low volumes and even with high pressures, how the lung actually get healthy. So that's why actually start with the volume. If you have volume problems, barotrauma. If you have PIP, then start. The second choice will be PIP. Be careful during weaning about atelectotrauma. And yesterday we talked about that study done by Martin Kisler, and he found actually the most two common ventilator associated trauma in his unit. His unit is actually volutrauma and atelectotrauma. You wean the baby, actually you drop the setting too much, so the lung get collapsed, so they go back, they escalate the setting up again, and actually collapse it. If the lung collapses, actually you will start again the process from zero and injury can happen. Limited change to one parameter at a time. This is actually, and this is very important, classic teaching. Don't like say if you have baby, CO2 is acceptable, so don't go drop PIP like from 20 to 16, in the same time decrease the rate from 50 to 30. No, just do one change. 30 minutes if you have really bad gas, if your CO2 like less than 35, so please 30 minutes later do another gas and see how much effective this change. Avoid change of large magnitude. As I mentioned, if you have baby in assist control rate 50 and you have CO2 acceptable 45, don't go immediately to shift this baby to pressure support ventilation. So just drop the rate to again from 50 to 40 or 35, and then 30 minutes to blood gas. Follow up blood gas after each change. This is another case actually. This is preterm, 23 weeks gestation, 3 weeks old. He was on high frequency ventilators. His MAB 12, amplitude 100%. We use actually high frequency trigger for small baby, and frequency 12 per second, FI2 40%. This is the blood gas for him. So any guess?
We don't use the half frequency عشان كده.
Yeah, no, it's okay. Yeah. I will tell you just some trick about high frequency in Draeger especially. What we do in Draeger, and it's very simple actually. You remember yesterday we talked about the oxygenation and ventilation, isn't it? And we said oxygenation is related to service area. If you would like to improve the oxygenation of the baby, you should increase the service area. You don't have other option, you know, like oxygen is slow, it diffuses very slowly. So that's why you should increase the surface area. In high frequency, the only way to increase the surface area is mean airway pressure. You don't have other option to do. So it's very simple. So if you like to improve oxygenation, increase the mean airway pressure. So this is the only option. You don't have other option high frequency. Okay. So this is for oxygenation. So what for ventilations? Okay. You have two parameters, isn't it? We said yesterday you can use the amplitude and the frequency. A Draeger, it's not typical high frequency. You know, like Draegers, if inshallah if we have workshop, we're going to talk about it. They use the amplitude in different way. So just a simple way for teaching what we'll do. We fix the amplitude on 100% and we leave it till we extubate the baby. So forget this parameter as does not exist. So we fix the amplitude on 100% and we leave it. So what we leave to manage the CO2? Frequency, isn't it? So you have one parameter for oxygenation and one parameter for ventilations on high frequency, which is the frequency. So this actually make it very simple to manage actually. It's not a complicated high frequency, especially on Draeger. So here you have frequency 12 and you have CO2 64, which is acceptable. But this baby actually have nearly cooked, isn't it? This is 23 weeks, I remember actually. And actually now she is actually about like 32 years old. She went up to 9 IVF in different areas, and this is the only time she can reach to 23 weeks. We actually informed them about complication, possibility of cerebral palsy, but they are insisted actually that to have this baby even if he's cerebral palsy. So that's why we decided to manage this baby. So this baby intubated, initially went to pulmonary hemorrhage, and then actually we shift him to high frequency. This baby stays more than 6 weeks on high frequency. But look for what's happened for him. Have chest tubes, have pneumothorax, so his lungs get bad. So here again it will cut. If you have this acceptable gas, if you have this acceptable gas, why I should stay? Why I shouldn't move the most harmful here? What's the most harmful actually factor in this? Is the main airway pressure the most harmful in this lung, or the frequency is the most harmful in this lung? This baby has pneumothorax, so you have problem of distension, isn't it? So that you would like to wean the mean airway pressure. Here in this scenario, the most harmful position, the most harmful parameter will be the mean airway pressure, isn't it? Because remember, on high frequency, the volume which is given, so the volumetrauma is minimal, is 0. This is the machine which is give you actually tidal volume, which is give you actually volume less than dead space. So you are not worried about volumetrauma on high frequency at all. So here you don't have the volumetrauma as a parameter, but actually you have the mean airway pressure. Here it become harmful parameter actually. So to keep this baby on 12 and his FiO2 40% and give you good PO2, so this is the most harmful parameter I would like to move. So the answer would be decrease man. Because you don't like to decrease the frequency. 64 is barely accepted for him. You don't like to increase the frequency. But as I mentioned, 64 is okay. So this is a full chest tube, so you can put the chest tube now, and this baby is still on MAP 12. So aminophyllin, actually, what's the benefit for aminophyllin high frequency baby? So you are not extubating the baby. There is no plan soon for this lung to be isn't it? Extubated. So this baby cannot be extubated. So that's why we didn't give aminophylline for the time being, because he is not ready to be extubated. So why I give the baby medication, extra medication, which can cause harm actually, and I'm not planning to benefit from this medication, because this medication helps for apnea, and I'm not planning to extubate the baby. So the only option is actually to decrease the MAP, because here, for this baby, for this case scenario, the most harmful parameter is the MAP. I didn't guarantee 100% that drop MAP will actually improve the baby. It may be actually improve, and it may be worsen the outcome. But at least you tried, isn't it? Sorry? So yesterday we have the talk about assist control. Okay. And we mentioned when you put the baby actually in assist control mode, actually, each breath will be supported. Remember yesterday's talk? So if your baby will assist control rate 60, then each breath the baby will take it will be 60. If the baby start to take 80, then the extra 20 will be also supported by the machine. So assist control to wean, decrease the PIB, remember barotrauma, but provide adequate. If you are using volume guarantee, just be sure your volume is 4 ml. And yesterday we talked about the study actually is that if they decrease the volume actually to 3 ml per kilo, actually in the study it shows actually this is increase actually the inflammatory cell from the lung. So they did actually, what they do bronchoalveolar lavage for this baby, and they actually ventilate them in different volume guarantee, 3 ml per kilo and 5 ml per kilo. They found the baby who are ventilated on 3 ml per kilo, actually they have bad lung, actually they have more inflammatory substance come from the lung. So this is actually at the starting of bronchopulmonary dysplasia. So that's why we don't use volume guarantee less than 4 actually ml per kilo. So if you are using volume guarantee, just go to 4 ml and forget about PIB. If you are using PIB, just this is the most harmful, so start to decrease the PIB. And keep the backup rate up to 25 to 30, and extubate directly or switch to SIV or PC. If you go to this rate actually to 30, then you can extubate, or you go to PSV or SIV according to your case and your expertise with the machine. This is the SIV mode. We don't use SIV mode, especially in high frequency triggers actually. It's not the best mode in this machine actually. And that's why if you see the new trigger, they add actually to it is a pressure support. So you have SIV combined with PC. In SLE it's combined actually. The problem is if you use SIV mode alone, what's happening actually? If you put the baby on rate 30 SIV, and the baby taken about like 60 breaths by his son. So the 30 will be supported by the machine, isn't it? And the other 30, it will not be supported. So what the study show actually, it shows that actually SIV mode increase the work of breathing actually. Why this is happening actually? Because as the baby is struggling to each time to get his breath on through the resistance of endotracheal tube. So as they remember the old practice on the rules they use endotracheal CPAP, and we never use endotracheal CPAP, and it's become obsolete and no one uses it now, and there is no recommendation to use endotracheal CPAP. Because it's actually increase the work of breathing. Actually the baby is struggling. Just like imagine, if you have straw, just put the straw in your mouth, close your nose actually, and start to breathe through the straw. Just to try for 5 to 10 minutes. That's exactly what happened if you use SIV in lower rate. So that's why to see many people they are not actually fan with using the SIV in the Draeger, and that's why actually in the new generation of Draeger they add SIV plus pressure support. So the baby, the breath which is the 30 breaths you give it by the machine, it will be SIV, but the other 30 it will be PSV. Okay, so the baby will not take any breath as endotracheal CPAP. So that's why if you have Draegers, just keep away from this mode for the time being. And again the same way, decrease PIB, decrease rate, keep the volume guarantee at 4, and then you can shift to BSV or you can extubate to CPAP. BSV actually this is the best mode actually in the machine. Remember yesterday I talked about it. It's actually this is the best mode actually in the machine because it's synchronized actually. It's completely synchronized. The inspiratory times for the baby to get it, the starting of breath actually and the end of breath is actually post synchronized. So this is the advantage of BSV. So VSV actually adjust level of PIV again to go actually low. So start with PIV, keep the volume the same actually principle, extubate if the baby is stable and you are sure that he is not apneic to low pressure. For high frequency actually the advantage yesterday we said of high frequency it's uncoupled oxygenation from ventilation. So you have the oxygen, you can manage it through the mean airway pressures, you have the ventilation or CO2 and you can manage it through the amplitude or frequency. So here they are completely uncoupled from each other and no one affect each other. So to decrease CO2 you either decrease the amplitude or actually may increase the frequency in the wing. And well oxygenated baby decrease FI2 till you less than 50% and then decrease the MAP. This is again, it's not evidence based, again we insist on it. Decrease the MAP to 10 to 12 so you can shift to conventional and MAP to 7, 8 actually, so with amplitude less than 20 and you can extubate to CPAP. Again, I don't like to mention it, it depends on your expertise actually and your staff how much they are expert in high frequency machines. If you have staff expert in high frequency, you can extubate the baby directly from high frequency to connect him to CPAP. Because you can go in very low and minimal setting on high frequency. You can go actually up to mean airway pressures of 7 and you can go actually at amplitude of 20 or 18. FiO2 actually can go to 25%. You stop your sedation 24 hours. You take actually the baby from high frequency to CPAP directly and baby will be okay. If you don't have this expertise in using high frequency, then if you reach actually again to MAP 10 to 12, then you can actually shift the baby to conventional ventilation. This is another case actually. This term baby 3 days old, he was on high frequency, his MAP was 13, his amplitude 24. This is the sensor medic. Remember this is a different machine of high frequency than the Draper. He's in MAP 13, his amplitude 24, his frequency 10 Hertz per second, FI2 50%, and this is a blood gas, 7.2, 64, 50, 25, and this is the X-ray of this baby. Yeah, exactly. So here the diagnosis is what? Congenital left diaphragmatic hernia, isn't it? So this is different patient and different scenario. Which one? Here decrease the MAP to decrease the MAP to 14. Yeah, sorry, yeah. So it should be higher. So either to increase the MAP to 14 or decrease the amplitude or increase the amplitude, decrease the frequency or increase the frequency. So remember, what about this setting in high frequency? It's more or less decent setting, isn't it? It's not that bad setting, like baby who's term baby and is taking MAP 13. So we said if he reach MAP 12, then you can shift him to conventional, isn't it? So we are close to move the baby to conventional. Amplitude 24, this actually is not bad. We are nearly double the mean airway pressure, which is very acceptable and decent also setting. Frequency 10, which is acceptable, isn't it? We said you can move up to 12 or 8 in frequency. FI2 50% is not bad, okay? But the question is, for congenital diaphragmatic hernia, is this gas acceptable for him or not? Like this 64 was acceptable actually in the last baby, isn't it? But the baby was 3 weeks old, he was preterm baby, isn't it? But here, is this gas acceptable for this baby? So what's the problem with baby? All of us encounter if a baby have congenital diaphragmatic pulmonary, pulmonary hyperplasia and pulmonary hypertension, severe pulmonary hypertension, severe BPHN, and that's why this baby is still on a 50% oxygen, and you see his PO2 is barely touching 50. So this baby still have pulmonary hypertension. If you have baby with severe pulmonary hypertension, are you going to accept pH 7.2? Are you going to accept BCO2 64 for him? Is this pH acceptable for this lung? It's actually, this will cause actually more pulmonary vasoconstriction, okay? And it worsens. So at least, like with intercomment using hyperventilations or actually high pH, but at least you should have normal range pH. So your pH should be 7.3. And actually, what's the acceptable parameter for baby with pulmonary hypertension? It's actually, sorry? No, we didn't go to this limit actually. We said it should be from 40 to 50. So we don't go. So here CO2 is very high. So that's why if you remember Dr. Demerdash's lectures, what happens if you move 10 from BCO2, isn't it? So actually it can increase, isn't it, to 7.3. So if you wash your CO2 to 54, then your pH will be 7.3. So this will help you to vasodilate the pulmonary circulation little bit. So here actually you cannot wean this baby. You need to escalate the setting actually, okay? So what you need actually here, you need to increase the amplitude. You need to wash CO2. Is it clear or confused?
سؤال المفروض هيزود
هيوش yeah.
What about increase frequency?
Yeah, it increase the frequency actually will accumulate CO2. Yesterday actually we did our presentation, remember about it. Yeah, remember we said if you increase the frequency actually, just one trick on high frequency. Someone didn't attend the lecture yesterday. In high frequency, the I time is fixed, 33%. Because it's like we ventilate the baby with 400, 600, 800 press per minute. So that's why the inspiratory time is fixed at 33%. So each time you increase the frequency, okay? So if you move like from 400 to 600, actually the I times will get shorter, isn't it? Because this is 33% of the breath cycle, of the respiratory cycle. So when you decrease the I time, actually the volume will decrease. So that's why increasing the rate will decrease the volume. Remember yesterday is about basic physiology we said. If the ventilation, which is related to CO2 or reflected by CO2, is mainly related to volume. If you would like to improve or wash CO2, you should increase the volume. You don't have other option. Okay? So oxygen we said related to surface area. We said CO2 related to ventilation, which is related to the volume of air which is in and out. So if you would like to improve the ventilation with CO2, you don't have other option than increasing the volume. So to increase the volume, you need to decrease the frequency, because if you decrease the frequency again, the I time 33%, so it will be more bigger with decreasing the frequency. This will increase the volume. Okay, so here actually increasing the amplitude, so as the option actually you can decrease the frequency. You can decrease the frequency also. But as I mentioned yesterday, remember, we said 10 is a quite acceptable actually frequency for most of our baby. We use from 8 to 12. We said the smaller the baby, you need higher frequency. This is the lecture we talk about. And also at the same time, actually the amplitude have double the effect on CO2 than frequency. So move one step by amplitude is better than to move 2 steps in frequency. So that's why at moving the amplitude to waste CO2 at least by 10, it will help the pH and it will be decreasing the pulmonary pressure. So the clinical trial of weaning actually, your main goal is to decrease the ventilation actually. This is the most important. And the argument we talk about it, assist control versus SIMV, yeah, it's just the idea of to be shorter duration. And this study actually, shorter duration of weaning from assist control than SIMV. And that's why actually I said, Dr. Atif actually and Dr. Demerddash yesterday was here, we don't use SIMV in our unit, honestly. So we move the baby from assist control to BSV diet. As we mentioned into that. If you go on low rate in SIMV, then you leave all the other breaths actually unsupported. So the baby is breathing by his own through endotracheal tube. So that's why we don't use SIV in our unit. And this is our practice. But it's supported by study that there is decreased duration of weaning on SIV than assist control. And as I mentioned, if you have a still easy combine SIV plus pressure support ventilation, the new mode actually of Draeger, they combine both SIV plus PSV. And again, also the study shows actually there is shorter duration of mechanical ventilation during the first 28 days in extremely pursued infant when SIV combined with PSV than SIV alone. If you don't have SIV combined with PSV, actually you can do assist control alone. And this will be CPAP. I think most of you attend many lectures for Dr. Hani Ali. He's pro CPAP. Stabilize the upper airway and improve lung functions and reduce the apnea. So this is actually cognitive data, or nearly actually the study of the Cochrane review. It shows actually using the CPAP, less apnea and bradycardia, less respiratory acidosis, less oxygen requirement, less need for re-intubation. And this is from Cochrane review or meta-analysis. So we have strong evidence, we have level A evidence to support using of CPAP or to extubate the baby to CPAP or to start CPAP from zero. And yesterday Dr. Ali talk about the using of CPAP as initial mode. And actually if you look for the New England journals, like last year they have published in ICH the D group data about using of the CPAP, and it was very encouraging result. You know, CPAP use actually it's depend on practice in your unit. And as I mentioned yesterday, right, Hani Ali had very nice presentation, but he just tell you the time you need it to establish your unit and learn your staff on a new practice. He moved from Columbia Children's Hospital to Washington DC, and their incidence actually of pulmonary dysplasia was about like 30%, but in, you know, like Columbia Children's Hospital, their incidence of bronchopulmonary dysplasia 4%. So actually the head of pediatric department in Washington, he would like actually to decrease the incidence of bronchopulmonary dysplasia. So that's why they recruit Hani Ali as a head section. And when he went, he started to learn his staff how to use the bubbles. And actually you can see the trend from 30% in first year, 1 year, complete 1 year, training the staff, the drop was about like 3 to 4%. So he need actually 3 years to reach the target to 8 or 9%. So this is the problems actually on implementing the new strategies actually. It's just like how to learn your staff, how to set your staff. As I mentioned always, the nurse actually is the main core of the NICU. You are the physicians, you go and you go around in 30 minutes, maximum 1 hour, and then you leave the baby for about like 12 hours or 16 hours, the care of the nurse. So they are not expert in using CPAP, in doing suction in CPAP, in doing handling the baby in CPAP, in actually in just how to cuddle the baby, how to swaddle the baby in CPAP, then definitely CPAP it will be fair. But definitely we have enough evidence actually to support CPAP. We get disappointed if someone following the literature after COIN trials. No, we are waiting for COIN trial to tell us that the CPAP is good, but unfortunately COIN trials done by Colin Morley, it shows actually increase the incidence of pneumothorax with the CPAP by 9%. But the details actually, they use higher CPAP. They start with beam 8 in the labor and delivery, and then when they went to the NICUs, they start to drop it to actually 5 and 6. But in ICHD groups, they start initially from 5 to 6, and their number of patients more actually. So that's why with the Cochrane review actually support using of the CPAP. This is actually, if someone attends the SPR actually last 2 years, there is actually more than actually 13 paper about using NIPPV, you know, like such as nasal intermittent positive pressure ventilation, and this actually we found to superior to CPAP. So your baby on the CPAP using whatever Draeger CPAP, so just shift to the mode using to intermittent mandatory ventilations, you give him extra 20, 30 breath extra through the CPAP. And what you use actually, if your CPAP level is 6, then your BIP it will be 3 times your CPAP. So you just adjusted like 18 over 6 or 20 over 6. They found actually this is decrease the incidence of apnea and also in the same time decrease the extubation failure. Chest physiotherapy, IV dexamethasone reduce the need for re-intubations. Anyone using IV dexamethasone?
prolonged duration.
Yeah, that's what we call it actually, short gain and long gain. Unfortunately, this is a typical area of when you use the dexamethasone. This is another issue actually. You can see actually the review done by Dr. Henry Halliday. This is the best review actually for using of dexamethasone. He divided actually to early, and then early late, and then the late one. He make actually the first 72 hours, and then first 2 weeks, and then after 2 weeks. Take it about 39 trials. We make it an analysis. And they have found actually the worst effect using dexamethasone was the first 7 days prior. And it directly related to cerebral palsy. You can see many studies actually after that came to support it. And depend on this study actually why we go back to repeated course of antenatal steroid. You know, like the common scenario was happening actually if the mom came 24 weeks, came with bleeding, the obstetricians will ask you, can I give Dexa? Yeah, of course, give Dexa. So he gave course of Dexa. Luckily the mom actually is stable. She went home. She came after 2 weeks again with bleeding. The obstetrician will phone you, can I give Dexa? Yeah, give antenatal Dexa. So you give another course of antenatal Dexa. She came after 1 week. She came with bleeding again. She needs delivery. Can I give Dexa? Yeah. Give Dexa because of delivery. So that actually there is in Lancet actually there is very nice study actually. It's called MAC trial. Multiple dose of antenatal steroid effect. And they found actually the baby was delivered after repeated dose of antenatal steroids, they have smaller head circumference. So it affects the brain growth. So this is very important. That's why we are not recommending now and we are not using the repeated antenatal steroid action. Maximum you can use one. In very rare actually in difficult scenario you can add 2 if there is multiple pregnancy, some say recommend, but maximum you cannot go more than 2 courses of antenatal steroid. So the steroid now has become an issue actually for us and youth. And if you look for the American Academy of Pediatric guideline and CBS, Canadian Pediatric Society guideline, they both recommend to get a consent from the parent before you use dexamethasone. So you tell them that I will use this medication because your baby cannot be extubated from this machine, and if he stay on this machine he will have cerebral palsy. And if I give him dexamethasone, there is possibility also to get cerebral palsy. So you share them in decisions, you document this in the chart, and after that you can start your course of antenatal steroid. Dexamethasone. So methylxanthine also improved the chance of successful extubations. Nasal CPAP, NIV, methylxanthine are evidence-based treatment to facilitate weaning and extubation of preterm infant. Chest physiotherapy and dexamethasone may be effective, but should not be used as routinely actually. If you remember nasal CPAP, we don't have problems in IPV. As I remember, LSPR last time have more than 16 trial. Methylxanthine was issue, isn't it? Till we get the CAB trial. Like the caffeine for apnea of prematurity. And if you look the protocols, I have the protocol actually, which is set to do the study for using of caffeine. What the idea of it actually? The idea came actually because methylxanthine, or actually it blocks the adenosine receptors in our brain. Adenosine receptors in our brain actually it regulates the blood during hypoxia. So if the baby went to hypoxia, it vasodilate, the baby got hyperoxia, it vasoconstrict. So it regulates the blood flow in the brain for preterm baby. So the idea came, the baby who will get methylxanthine or methylxanthine, anti-adenosine, they will get worse outcome. It's actually the protocol set for this, for the CAB trial. And the result actually, it came completely opposite to what we suspected. The baby who gets, in summary, the baby who gets aminophylline or methylxanthine, they have better outcome actually than the baby who are not receiving aminophylline or methylxanthine. There is many discussions and still many people are coming about it, but till now we have enough evidence to support the using of methylxanthine. So this case 6, this is Peter, baby 30-week gestation, 3-hour-old. He is using CPAP 7 cm and FI to 60%, and this is the blood gas for him, and this is his chest X-ray. So for our resident, what you will do? You will increase the CPAP to 8, as we have enough evidence to support using CPAP. You will use aminophylline plus CPAP, because we mentioned we have enough evidence to support using aminophylline. Again, we will wait and just repeat the blood gas 2 hours till next shift come to baby, and intubate, start mechanical ventilation, or use insure.
يتحسن. That's why you must stop.
Remember yesterday we talked about if you're gonna do start intervention, the first thing you should think about it, what's the limitation of your intervention. If you're gonna start nasal cannula, which is about 0.2 to 0.3 in diameter, tiny nasal cannula for the baby, you should know before you start at what time you're going to stop this nasal cannula, or at what time you're going to say this nasal cannula failed. Okay? So you have line, or you know your limitation. So each unit actually, they have their clinical practice guideline for the limitation of each intervention they're going to use. If you're using nasal cannula, what's the limitation to stop? In our hospital actual guideline, is that if I do increase more than 40%, then this machine should be stopped, or should nasal cannula stop, and look for other interventions. Okay. The same. What's the limitation of using CPAP? We said CPAP is effective. CPAP is very good. Decrease apnea prematurity, decrease re-intubations, and improve oxygenation. But what's the limitation of CPAP? What's my limitation? I use CPAP 5, I use CPAP 6, I use CPAP 7, I use CPAP 8, I use CPAP 9, I can go to CPAP 10. What's my limitation? And what's my FiO2? So that's why you should have criteria in your learning, or you have clinical practice guideline. So you tell your staff, or you have already your staff, they have full idea about when to say or to phone and tell you that this baby needs intubation, because CPAP failed and he needs conventional ventilation. So this baby is taking CPAP 7 and 60%. In our unit, again, this is our clinical practice guideline. It's not 100% evidence-based. It's not level A or not even level B. In our unit, we put the maximum CPAP you can go is actually, you can go to 7 if the baby have bad RDS, but FiO2, we don't like it to be more than 40% at all in CPAP. Okay? You know, like higher oxygen cause a lot of oxidant stress actually, and this we know that this baby, they don't have antioxidant. So if you keep the baby on higher FiO2, you will get chronic lung disease, you get BVL, you get even necrotizing enterocolitis from the oxidant exposure. So that's why our limitation is maximum 40%. Especially in baby preterm babies, this baby is 30 weeks. So we have another problem actually. This baby deficient with, he don't have surfactant. So here, you know, it's alveolized or secure. It's collapsed completely each time the baby go in. So if you keep him, the baby will end with chronic lung disease. So this baby actually, he reached the maximum of CPAP. We said our maximum in our units, and as I mentioned, this is not standard, but you can go to CPAP 6, and FiO2 maximum to go more, you shouldn't go more than 40%. If you reach this setting, then do something else, because this CPAP intervention failed already. So what you will do? Are you going to increase CPAP to 8? For us this is the maximum, and I will tell you something else. If you reach CPAP to 8, you remember I told you about COIN trial? When they start with higher CPAP, start with CPAP 8, they have higher incidence of pneumothorax. And the bad scenario actually for preterm baby to get pneumothorax. What happened to the preterm baby if they get pneumothorax? The baby will get pneumothorax, the cerebral pressures will drop, because it's following the systemic, they don't have blood-brain barrier regulation, so the cerebral pressures will drop. You put your chest tubes, you give bolus of normal saline, you increase the cerebral blood pressures again, so the baby will get IVH. So this is the problem. It's not only the lung. You can put your chest tubes, and you are good in putting the chest tube, but the problem, the head actually will be cooked. So that's why we don't like pneumothorax, and you shouldn't have actually pneumothorax in your unit. So that's why actually increasing CPAP to 8, it will shift you to the COIN trial, and this is evidence-based medicine, shift you to Colin-Morley study, and it will cause pneumothorax, and we don't like. So the baby will not benefit. So we give aminophylline and decrease CPAP to 8. This baby problem is not apnea, isn't it? This baby problem is oxygen. So he don't have apnea, so aminophylline here will not add anything to you. You're going to repeat blood gas in 2 hours. Again, if you have problems, don't push it, okay? Just deal with it. So here, you cannot postpone to 2 hours later, isn't it? Because the problem is still, and actually this baby is 3 hours old. After 2 hours, he will be worse. Because we know the course of RDS getting gradually worse, isn't it? You intubate and start mechanical ventilation? Isn't it? Yes. You will use Ensure. What's Ensure? Remember yesterday? Yes, Dr. Demerdashan thinks of Dr. Alice spoke about the Ensure. In for intubation, surfactant, and E for extubation. What they did actually, the first study actually came, which is the insurance trial. They found actually this baby from 29 weeker to 33 weeker. So they select this age group. They go away from the tiny small baby. They get the 29 weeker to 33 weeker. And they have the consent or the hypothesis. They got the hypothesis in the study that this baby actually they are deficient in surfactant. Some of them they are deficient in surfactant. So if we give them the surfactant and immediately we take the tube and connect them to the CPAP, this baby they may do it. And they do this 2-arm study. And the outcome was excellent actually for them. So you intubate the baby, you give the surfactant back for 1 or 2 minutes, take the tube, connect the baby back to CPAP. You don't do chest X-ray to check your 80 tubes. You then take time, 5 to 10 minutes maximum the baby intubated. Give the surfactant, take the tube out, connect. This is the idea of insurance. And this will be the best for this age group. So the baby problem is surfactant deficiency. Nothing will help. To increase CPAP to 8 will not help. Maybe you get pneumothorax. Increase aminofillins will not help your oxygenations at all. Repeat blood gas in 2 hours, as I mentioned. It will actually, the baby will see the baby will become worse. Intubate, start mechanical ventilation. This is clinical practice and you can do it. But this is not the best practice actually to do. Because as we mentioned earlier, each 1 day the baby stays on mechanical ventilation to increase the incidence of cerebral pulse. So you have another practice, and this practice actually evidence-based. So you can intubate, give surfactant, take the tube out, connect the baby back to CPAP. It's actually the initial study done for 29 to 33 weekers. But just go now on the internet or PubMed, we'll see many studies come to 24, 25 weekers. They do intubate, they do get surfactant, they extubate, and they put back in CPAP.
طب البريشر اللي حضرتك بتفضلوا فيه البيتيرم بيبي اللي هو الستات بريشر that will not affect the venous rhythm.
It's actually honestly wouldn't go more than 6 actually, as I mentioned. But actually the team, what they are trying, they found the baby is 30 weeks. He have good gestation. So they said if we try 2 hours from CPAP 6 to CPAP 7, we may gain something. We may open the lungs, we may distend the lungs, and opening the lung and distending, it will help surfactant to recycle. So that's why they said it may be help, it will be help. So that's why actually they decided to increase CPAP to 7. But actually he was on 50%, actually oxygen requirement gradually, because the baby getting worse, increased to 60%. So that's why the option was insured. So this is the insured method actually, and you can see this is Cochrane review. Okay, so what they found actually, less need for mechanical ventilation, so they use the insured actually, lower incidence of bronchopulmonary dysplasia, fewer air leaks, so less pneumothorax. So less need for mechanical ventilation if you use the insured method, lower incidence of bronchopulmonary dysplasia, and this is affecting your developmental outcome as we mentioned, and less incidence of pneumothorax or air leaks. So with the using insured. So again, why we don't use it? So it's very simple method, can be done very easily, don't need a lot of effort.
When you will extubate?
Immediately. So what we are doing actually, immediately we get the baby, we put the baby in the resuscitators, we intubate, surfactant already prepared baby, we give the surfactant, few puff, we take the tube out, we connect the baby back to the CPAP, and we return.
You don't do blood gas between?
No blood gas, no chest X-ray, nothing. We give the surfactant, put the baby back to the CPAP, and then 1 hour, 2 hours we will run. This is the insurance.
But this patient is not stabilized and
No. He is stable, but he has respiratory problems. Actually, we didn't talk about the baby who have severe hypertension and he's in 1 or 2 electrodes. That's what I told you. That's why the scenario is 30 weeks. This baby is 30 weeks. Most of the babies 30 weeks are hemodynamically stable. If you have baby on 2 inotropes and baby sick or baby septic, this baby definitely is not ready for. Yeah, so if the baby have only respiratory problems, you have the baby breathing by his own, actually have good respiratory effort, and the only problem is the surfactant deficiency, isn't it? This baby, you don't have only problem is surfactant deficiency. So why don't you give the surfactant and take it back out? It's actually, we have visitor professor from Germany and shows the experience, what they are doing actually, because they know the tube is back. And he did it actually in our hospital. He came to our hospital. He just puts the laryngoscope, he puts the OG for 3 centimeters, he pushes the surfactant, he takes the OG back again, and we put the baby in the seat. So this is we don't do it, but he came to our hospital as visiting the office, and he did it actually. And he said this is common practice, they use it in Germany, and they publish. No, this is another issue actually. A problem if you read evidence-based medicine, we read the English literature only. And you see the Cochrane reviews said we review the English literature only. No? You see the Germans, they have many publications and they have a different experience actually. This guy, he came to our hospital, he helped us a lot because we didn't read the literature which is written by German or Dutch. We didn't read actually the literature which is written by Japan, and they are doing a very good job. Now Chinese actually they have many publications, and most of the time we didn't read. So our evidence-based medicine actually, what we say level 1 or 2 or 3, it's actually we completely dependent on the English language only. So this is what's experience. But he said we use it commonly. Very rarely we intubate the baby. We just put the OG, we give the surfactant, we take it away. So this is the idea. No chest X-rays, the babies didn't sleep yet. Sorry? From the birth actually. There is some study what they did. They take the baby immediately. This is, as I mentioned, this is the first insured trial which is done 29 to 33 weeks is the first insured. But after that actually some people what they say, they have like some sort of, if the baby, this is someone study back, if the baby is than 28 weeks, they intubate immediately, they give the surfactant immediately after delivery. They intubate, they give surfactant, they take actually the tube out, they connect the baby to CPAP and they take it. So there is no time limit for it. Sometimes we do it in second days. Like you see baby actually stable, is CPAP 6, is FI2 30-35%, but in second day we are doing our round and we see the baby is more technically, requires higher oxygen. We do X-ray, we're sure that there is no pneumothorax, no other factor. It's taking good CPAP, the baby has picture of RBS. So we ask our staff to just do insure, put the tubes in, give surfactant, take the tube out, bat the baby to CPAP. And as I mentioned, you cannot argue with Cochrane review. This is Cochrane review studies. They have now many trials actually, and they found this need mechanical ventilations, lower incidence of bronchopulmonary dysplasia, and fewer ALD. Suppose actually 3 very bad effects can be prevented by insurance. As I mentioned, actually something can help you in weaning. CPAP can help you. There is pharmacological agents like semicylzanthine, caffeine, nutrition, as I mentioned, and corticosteroids. For mesylzanthine, the effect increase central respiratory drive, increase the diaphragmatic contractility, increase the lung compliance. This is through diuretic effect. Adenosine antagonists reduce the neural protection. This was the concern which is already we talk about it again. Actually, this is very like there is a few articles which should change our practice again. And that's why actually I put the CAP trials for the caffeine for apnea of prematurity. It's actually the objective or main objective of this study was to define the short-term and long-term benefit and risk of caffeine in babies from body weight 500 to 1250 grams per day. And this study actually published in New England Journal in 2006. So you are familiar with PICO system, isn't it? Like, just like if you like, like this is the first the first chapter in evidence-based medicine. If you like to have questions, you should formulate questions, isn't it? And the way to formulate a question is the PICO system, like the population, the intervention, the comparison, and the outcomes. Okay? If you would like to see like paracetamol effect on vaccination, so how you search it in the internet? If someone told you, well, my child get vaccinated and I don't want to give him paracetamol or not. So for you as a resident, how to search it, how to answer this? You have the PubMed, and PubMed is free, isn't it? At least you can get the abstract and you can read it. So and it's free for everyone. So this is the idea to formulate questions. You should remember this PICO system. So populations, what? For who get vaccinated, you can write children's or feverish children or vaccinated children. This is your populations. What the intervention is paracetamol, isn't it? You'd like to see if it's paracetamol effective or not. And what's the placebo? What's the control? Control with what paracetamol? You'd like to see if the baby vaccinated and give him paracetamol, and the baby who are vaccinated and they don't receive paracetamol. And you see the effect of it. Is it decrease the pain? Is it decrease the itching? Is it decrease the irritability? Is it decrease the redness? Is it decrease the effectiveness? So, and the outcome, improve rate of survival without cerebral palsy in very low birth weight. So here is outcome. So this is the idea of PICO system. Always when you would like to search in the PubMed, just formulate your questions depend on PICO system. And from the PICO system, actually you can get the answer very easily. So here, populations actually use 2006 infant. So this is a CAB trial when it was done actually, when it was done, it was the largest randomized control trials in neonatology. So it was 1,000 in each arm. And they use methylxanthine because it's the multi-centers. So some units they use aminophylline, some units they use caffeine. And the other arm actually they will not receive anything, placebo. And the outcome improves survival without cerebral palsy. I mean, like, the idea of outcome here is excellent. So they didn't look for bronchopulmonary dysplasia. So look what they are looking for. Actually, this study actually they look for cerebral palsy. Because they know all this actually at the end, methylxanthine affect adenosine receptor, so it can cause cerebral palsy. Okay? Bronchopulmonary dysplasia can end with cerebral palsy. So they choose the outcome here. It's actually the most important outcome. Okay? Although they are using medication which is interfere with the respiratory drives and they have something to do with just extubation, so they choose the outcome on neurodevelopmental outcome. So that's why it makes this study actually something of our cornerstones in our neonatology practice. So the caffeine group, the study result, what was found? In the caffeine group, there is shorter duration of respiratory support, less bronchopulmonary dysplasia, less weight gain, and less BDA. This is in the first 3 weeks. This is the Parpar-Schmidl study. And this is the outcome actually. You can see here, the composite outcome actually, it didn't make a difference. It's significantly different. But actually, I mean here, when they divided each other actually, the stars didn't found different. So this or this ability, they combine it together. This ability alone, it didn't make a difference. But this, with this ability, it make a difference in outcome and it make a significant outcome. Using postnatal corticosteroid for chronic lung disease, meta-analysis shows that infants at high risk of bronchopulmonary could facilitate extubation and reduce extubation failures, and this is a cocktail review.
How many doses?
Yeah, we'll talk about it just in one. So this is Henry Halliday. We invited him actually in our hospital. Stay with us about 2 weeks. He has visited the professor. He did actually, the early, which is less than 8 days, he combined both together. Use of dexamethasone has many adverse effects. Gastrointestinal bleedings, bowel perforation, adverse neurodevelopmental outcome. You know, bowel perforation, especially if it's combined with endomethacin. So this is a problem. And the study aborted actually. There is one study actually is aborted because of bowel perforation. They do the protocol and they found actually in the first week of life, the baby gets steroid plus endomethacin, they have significantly higher incidence of bowel perforations. You know now in randomized controlled trials, in just middle trials or in the quarter of the trial, you should stop and review your data. And if you see harm, there is great harm, you know the ethical committee asks you to stop the trial. So that's what happened with them. And this is one of the benefits of interim analysis. You know, if you are doing the study, you know the ethical committee asks you to do each time to do interim analysis. Stop here, do analysis. Someone getting more harm. So what happened actually? They found combination of endomethacin and steroid caused bowel perforation of first week of life. So that's why they stopped the study and the study aborted actually. And as I mentioned, this is a recommendation of American Academy of Pediatrics and actually CBS, Canadian Pediatric Study, currently used as a risk therapy for preterm infant with the failed extubations. What we are using now is the DART protocol. This is the answer of your questions. Just before to go to this, again, this is not evidence-based. Steroid shouldn't be used. This is first of all. If you would like to use it and you feel the baby stuck to ventilation, to mechanical ventilation for longer times, don't use it in first 8 days of life. So don't use it in first week of life. So this is second rule. Third rule, as definition, what dose you're going to use? Are you going to use 0.1? Are you going to use 0.2? Are you going to use 0.3? Are you going to use 0.5? There is many controversy about this. The DART protocol actually, which is published about 3 years ago, it's not, they didn't complete the study because they have problem in recruitment. This is study actually they decided to give first 3 days of life 0.15. They use a tiny dosage, 0.15 milligram per kilo per day divided in 2 doses, and then 0.1 for another 3 days milligram per kilo divided in 3 days, and then 0.05 for the another 3 days. So over 9 days they wean the baby completely from the steroid. This is the DART protocol. They start to do the study, but the recommendation of American Academy of Pediatrics that if you would like to start the steroid, you should get parent consent. The CBS also recommendation, you should get parent consent. You know, the recruitment is become very, very low. So after 3 years they stop the trials and they publish it actually, but it's not complete trial. So we cannot depend on the result. But sometimes actually in our unit we use steroid. If we use steroid, we use the dexamethasone, we use the DART trials. It's low dose, 9 days course, and usually it gives you good result. But if you start to use the DART protocol, the trick of it, if you didn't get benefit from the first 3 days, where you give him 0.15 milligram per kilo of steroid, if you didn't get benefit of this, and you win the baby so rapidly actually, so quick, and you accept permissive hypercapnia, you will lose the benefit of steroid. And as I mentioned, remember steroid, what we said always is this is short gain and long gain. You can extubate the baby now, but the baby will have cerebral palsy later. So this is a short gain and long gain. This is case number 7. Preterm baby, 26-week gestation, have 30 days old. See, 30 days old. He's an assist control rate 60, volume guarantee 5 ml per kilo, I time 0.3, 5 to 40%. This is the pH. 7.2, 64, PO2 50, bicarb 25, X minus 27. And this is the X-ray of this baby. So what you will do with this baby? So to extubate to CPAP, to decrease VG to 4, decrease beep to 5, shift to high frequency, and give steroid.
Only steroids and steroids in the rectus. You don't have more steroids.
So you have preterm, 30 days old, isn't it? 4 weeks old. You have very bad lungs, bronchopulmonary dysplasia. You know, just comment about bronchopulmonary dysplasia. There is very nice article actually by Alan Job about the new and old bronchopulmonary dysplasia. The old bronchopulmonary dysplasia, which is described by Northway and Philip actually, which is oxygen plus pressure plus time, is completely different. It's completely different than the new bronchopulmonary dysplasia. This is a typical X-ray of the new bronchopulmonary dysplasia. You know, like this baby have big saccules, they don't have alveoli. So actually the problem is the collapsing of the saccules, which will give you this lung volume. So they need good distending pressure, they need good volume. The old BBD, which is described by Northway, actually was atelectasis, was collapse, was pneumonic batches. You can see the X-ray, it looks like meconium aspirations X-ray picture. This is the old bronchopulmonary dysplasia. And you remember the group which is described by Northway for old BBD, this is a baby whose body weight was 2.2, 2.5 kilograms. So these are different pathology actually. So the old BBD is completely different than what we see now in the new BBD. So that's why just be careful. So always you will see the X-ray more or less like this picture. Little bit hazy, that's all what you see in BBD. It's not like the area of collapse and atelectasis, and if you do pathology you will see a lot of fibrous tissue. No, this is the old BBD. Now we are doing the new BBD. And you remember the president, this is the unlucky family of Kennedy, you know, like their baby was delivered. Actually he was 33 weeks, and this baby actually have RDS. This was delivered in state, and they was like actually at this time actually second children hospitals in Canada. They start to do mechanical ventilation for preterm baby. And after a discussion, this is very nice story. Actually, they decided to move on to Canada. Two members in late 60 and early 70. There is big competitions at these times, and this is a Cold War times between USA and Russia. And you remember the Gorbachev story he showed. He said we'll leave the States and we'll go back. So that's why so they decided not to send him to Canada to the sick kid. So that's why they decided to send him to America. And you know what they are treating this baby 2.2 kg? They treat him with hyperbaric oxygen. So he's after 24 hours he died from hypothermia. So that's why actually old BBD is completely different than the new BBD. So the new BBD always you will see this picture, so you will not see the old picture. So it's little hazy, and that's all what you will see in the BBD. And sometimes actually you see clear, nice X-ray, but the baby is still requiring oxygen. Because now we ventilate our baby actually, they are in saccular state. If you look for the lung development, not alveolar stage, they don't have alveoli actually. They are, alveoli start to develop after 36 weeks. So we are in saccular stage. So what we are ventilating is big alveoli. So you are ventilating, the saccule is get many divisions, and each saccule is form about 8 to 10 alveoli. But this baby actually they have big saccule. So to keep this big saccule inflated, you need very good beep, you need good volume or acceptable volume. So if the baby went to, actually for you, if he went to bronchopulmonary dysplasia, you should be sure that this baby have at least good beep, at least beep 6, sometimes actually beep 7. Our practice sometimes we go to beep 8 actually in baby with a bronchopulmonary dysplasia to keep this baby extubated. So what you will do in this baby? So this baby have bronchopulmonary dysplasia. This is his blood gas, and this is his ventilator setting. So what you will do? This baby is sick, isn't it? This baby is sick, isn't it? Look for this setting, you can see he is already 30 days old, he is rate 60, he is in 5 ml per kilo, and this is the maximum. Remember yesterday we said we talk about our criteria to shift the baby to high frequency. We said the maximum volume guarantee we go to 5, and after that you go to higher frequency, and I time point to 3-5 seconds, FI2 40%. And this is the gas for this baby. Is this gas good for this baby or bad for this baby? So do you would like to wean, or you would like to escalate your setting now? What you will do for this baby? Or you would like to wean or to escalate? Is this baby acceptable for this? Is this gas acceptable for this baby in this condition or not? Yeah, it's acceptable. It's good actually. It's good. Take the opportunity. Have acceptable gas. Okay. 7.264. You know what is the acceptable CO2? For this baby at this age group, most of the hospital, they accept up to 70 CO2. We put our guideline and protocol, actually the acceptable BCO2 for baby more than 5 days, for preterm baby more than 5 days, we accept 55 to 70 CO2. So if you have this opportunity, this means in our normal range to accept it. Because again, as we mentioned, if you get this sick lung, to give you acceptable, to give you normal gas, then you will cook this lung and the baby will die. So that's why this baby is very sick. So that's why you should go back a little bit in your setting. You should have permissive hypercapnia to pass this storm. So here you have CO264, it's acceptable. BO2 is very good. Bicarb is okay. So what you will do here? So the questions here. I would like to wean. Yes and no. Why not? Why you don't like to move? If you have good ground now you have little bit solid ground. Why you don't like to move? So this baby actually, by this bad lung, now his lungs start to improve and he gives you the acceptable gas. So you can move, isn't it? You should move, isn't it? You should wean. If you wait for this baby to give you good gas or normal gas, he will never give it to you. So if you have acceptable gas, just move to the next step. If you wean this baby and you found CO2, I will give you the scenario. If you wean this baby and you found CO2 75, okay? So you go back to your setting, isn't it? I will give you the, if you did not wean this baby and you found CO2 45, which is better scenario for you? Which is better scenario? Not to wean and after 4 or 6 hours you see CO2 45 for this lung, or you will wean and you get CO2 75 and you turn back. Which is better scenario for this lung? Yeah, to get higher, because if you go to 45, this means you cooked this lung. This lung will be cooked, and at the end you will have BBD, and this baby actually may die on ventilator. You know what happened? This baby, some unit actually, if they see this baby on the unit, like this FiO2 40%, if FiO2 increase by 10%, they do for this baby septic workup and start human antibody. Because pneumonia for this baby you cannot catch. This baby can go in few hours because pneumonia. Like this baby have cooked lung, you have nearly everything destroyed, have many explode here. So if the baby can get pneumonia easily, and it's very difficult to detect it. So if oxygen got so less, you are doing down on baby J or baby B or baby F, and this baby is chronic lung, he's 30 days old, and each time you go do round, you say the baby is 40 or 50%. But in one day you come to do round, this baby is 60% for the last 2 hours. Why FiO2 increase? You do X-rays, okay, the baby is active, the baby is doing well. So what's the problem? This baby could have pneumonia, and this is typical the starting of pneumonia. Little bit increase in FiO2 or little bit increase in change. If you wait till give you the full picture of pneumonia, I'm sure you cannot catch this baby. So that's why this baby is prone to get complications. So if you have acceptable gas, you should move. So if you decided to wean, which is the most harmful parameter in this setting? Is the rate 60 for this baby harmful? Definitely not, because this is a normal respiratory rate from 40 to 60. So it is a normal range, okay? So definitely not. Is the volume guarantee of harmful parameters? Yes, we said yesterday the most common lung trauma in the unit is the volume trauma and atelectal trauma. So here 5 is too much for this baby. So here I time is not problem, FiO2. So here we should move, because even if your CO2 go from 64 to 65, 66, 68, even if it is in 70, it's acceptable for this lung. Okay, this is the idea of permissive hypercapnia. Just you would like to improve outcome, you would like to move, you would like to extubate the baby. So here the answer is to decrease volume guarantee to 4. Okay? So because here is the most harmful in this setting, the most harmful parameter is the volume trauma or the volume guarantee. Yeah, this is actually animal study actually. Delayed extubation resulted in worse physiological measurement and increased episodes of apnea that require more re-intubation and additional time to mechanical ventilation. This is done in baboon actually in animal study. And the explanation it may be related to volume trauma, or there is start colonization of the endotracheal tubes. Most of the time we stop actually to do endotracheal cultures because it's useless, especially in Guinea. We don't have criteria how to diagnose what's the patient of it. So that's why most. But if you're doing actually endotracheal, many times you will see many bugs. You can see gram-positive foci, you can see gram-negative bacilli. Is this colonization or infection? Most of the time it's colonization. But this colonization actually in small baby it can change to infection very easily, and it won't cause a lot of trauma to the baby. So this is the idea of keeping the baby on intubation. I will just give you this quiz. This unit actually, and this paper is just published in 2009 in pediatrics, so it's new practice, it's not. So what's this unit actually? 1 year before the intervention, this is small baby, extremely low birth weight baby, less than 1 kilo. They keep the baby actually intubated for the average of about like 18 days, and some babies they stay up to 40 days. So this is a baby who are less than 1 kilo. This is before the intervention. They did some intervention, and 1 year later, they found actually the intubations average dropped to about 4 days. Okay, and another year more or less the same. So first of all, is this a great result or not? It's significant. Like so you drop the intubation rate from 18 days to 4 days. So the average days, so the baby who are extreme low birth weight, less than 1 kilo, they can stay actually up to 18 days, most of them, 50% of them, they can stay 18 days on mechanical ventilation. They did some intervention, they implemented, they learned their stuff. After 1 year, they do auditing for their intervention, and they found actually the baby who stayed on mechanical ventilation only for 4 days, or 4.5 days. So this is something good or bad? Excellent, isn't it? Excellent. So from average, from about 14 days, they dropped average to 18 days, and actually the mean was about like 4 to 4.5 days. So what intervention do you think they did in their life? did good results. If you have preterm baby and they stay incubated for about 40 days, you drop it to 18 days, and the average from 18 days, you drop it to 4 days. So the number or the days on mechanical ventilation, you reduce it dramatically. So what he did? But surfactant could help. But this study is published in 2009. So like surfactant was already practiced, isn't it? Any guess? No, it's not the issue. No, not the high frequency. No, it is in 209. Most of our practice early actually. It's very important, but they don't like they have already infectious control. No, it's not significant. I will tell you just the age group. 27 weaker, this is the average before the intervention. After the intervention, 27 weaker, and after the first 27. So their body weight is average is 800 grams. So it's not big baby, isn't it? So this is the 800 gram baby, and actually you get this result. So what do you think they say? It's very simple thing. No, not conduct. They did very simple. Very simple, no. So that's what it. The teams, they decided to eat together. Why our rate? Why our babies stay longer time than any other unit on mechanical ventilation? So they found actually many babies, they have pH 7.3, CO2 40, and they stayed another day. Second day, someone go around, found CO2 go up to 50. Okay, suction the baby, so the CO2 go back to 40. So that's okay. Let's wait because the baby just sees up. So they decided to set protocol. They learn their resident, they learn their nurses, they allow the nurse actually to call the consultant of the resident to follow the protocol, and actually they start to implement the protocol hard. So what they did only, they just set and they did the protocol and guideline. And they said infant blood gas were kept within the targeted level, pH 7.22, and between 7.22 to 7.35, BC2 45 to 55, and PO2 45 to 60. This is their need. For a chronic ventilated infant, which is 5 days of age or 5 days under mechanical ventilation, they need pH to be 7.20, 7.4, CO2 50 to 70. And what we are doing also in our hospital. We remember we said this is a permissive hypercapnia. We don't like any CO2 now for any baby actually. Any CO2 for any baby to be less than 45. Any CO2 for any baby, pulmonary hypertension, preterm baby, whatever, should be less than 45. Okay? So for the first 5 days, this is acceptable. 45 to more than 5 days, 50 to 7. That's all what they did. And they said patients were considered for extubation at the following setting: if birth weight less than 1 kilo, and on mass less than 7, and FI2 less than 30%. If the baby more than 1 kilo, they need MAP to be around 8 or less than 8, and FI2 is the same, less than 30%. All the infants were extubated to the CPAP. Okay? Surfactant was given early, within 2 hours, to any preterm infant submitted to mechanical ventilation. So this is a guideline, which is already they have it before. They used to give surfactant also before. But if you decided to intubate any preterm baby, in first few days life, for the respiratory, just give the surfactant at the time. So this is the protocol they set. They didn't do anything more than this. And you can see actually, first extubation attempt decreased significantly from 5 days before to 1.2 days. Okay, rate of extubation failure even decreased. So the extubation failure even decreased from 40% before the intervention, 26% first year after intervention, 20% second year after the intervention. Okay? After they just sit together and they decided to do protocol and guideline. And that's why actually, very important actually, in each unit now, they should have their own policy and procedure. They sit together, they see what resource they have. What resource they have. They don't have inhaled nitric oxide. Okay, I will use sildenafil. But I should put guideline for my staff how I use SIMD and what dose I'm going to start and what the mean airway pressure I need and what the FiO2 I need to start the sildenafil on. I don't have sildenafil, I have magnesium sulfate. Okay, what's the criteria of magnesium sulfate? Remember, magnesium sulfate has very bad side effect. Can cause severe hypotension, stay longer time. Can cause the baby actually to be flaccid and the baby can stay intubated. So, what criteria? What's your guideline for using each medication used? So that's exactly what it is. As you can see, their study actually was amazing result for them. So this is actually all the practice I just added, and if you see, this is reference to 203, but you see our change in our practice. Before it was less than 28, the acceptable page 7.25 to 7.35. This is a Goldsmith, if someone reading the Goldsmith, this is all the practice. No one accepts this actually. We go even more now. We give to 7.2, we give 7.19, we accept it, 7.1.8, we said it's okay, and CO2 55 to 60 is okay, and PO2 50 to 65. 28 to 34 week to 40 week, 25 to 744, CO2 same 45 to 55. This is a bad practice. Next, most of the people who are doing, they read from Goldsmith. And we add this slide actually to see, to tell you that this is CO2 30 is not acceptable anymore. Okay. So that's why we add this slide. So that's why even pulmonary hypertension, 7.35 to 7.45, this is the maximum. This is not acceptable anymore. No one accepts actually 30. So it's actually 40 to 50. So just be careful. And this is because that's why we always mention that usually they have actually, they don't have the enough or the update information. Like if you read book was published in 2011, definitely the knowledge it will be like the last and most updated knowledge in this book will be 209. So that's why it's not the best practice. So if you're reading all this mess, just avoid this mistake. And as I mentioned here, we go higher up to 70. So we can grab all this. Weaning clinical pharmacology is it's actually state of art than state of science. As you can see from the different scenarios, the idea just look for your baby. Is this blood gas acceptable for this baby or not? Okay, this is the first thing you need to know. And then, am I going to wean this baby or not? If I'm going to wean this baby, what parameter I will choose? What's the most harmful parameter I will start? If I have volume trauma, I will go with. If I don't have volume guarantee, then barotrauma is another factor. If I don't have barotrauma, then I look for the other factor which can cause a trauma. Weaning should be planned according to clearly, this is the most important, clinical and physiological goals. And the idea you should have your guidelines and clinical practice guideline in each intensive care. Clinicians have a choice of weaning technique. Definitely, this is very important. Look for your people expertise. As I mentioned, some units they extubate from high frequency to CPAP because they are staff familiar, trained very well on high frequency. So thank you very much. Any questions here?
I have two questions. First about nasal IBVP and side effects concerning GIT. And second about some tests about prediction of successful extubation, such as continuous breathing test. What's your experience?
No, I mean like side effect of CPAP in IVP and GI is nothing more than gastric distensions and feeding interference. There is no reports actually or literature support that it causes necrotizing enterocolitis, and this is our fear. Actually, in our practice, actually, honestly, in small baby actually, most of us, and not all of us, they believe in glycerin suppository. They believe in using glycerin suppository twice per day, especially for baby who are less than 750 grams. But the problem is actually, this baby is starting on small amount of feedings, and actually this baby does not have enough muscle to strain, and sometimes actually constipation can cause apnea for this baby. Plus, to add to them, we use it, but for NIBBV or CPAP, they have nothing to do with the necrotizing. The maximum is abdominal distension, and what they call it belly CPAP. I'm sure you read this expression. We do X-ray, X-ray is normal, this is just belly CPAP, so it's okay, we accept it. We put OG, and they are allowed to get free airway. This is the first question. Second question is predictions of extubation. And there is many trial done, but actually there is no trials actually can give you level A or B evidence methods to implement some of this. And just for other people, some they would like to know if this baby is going to succeed extubation or not. So some of them tried 30 minutes endotracheal CPAP. So there is one trial, what they said the baby in BCV or assist control or SIMV will allow him 30 minutes on just endotracheal CPAP. And we will see if he don't have apnea, if he don't have heart, then this baby will to succeed. But this study actually didn't show difference, first part of it. Second part of it actually again we go back to endotracheal CPAP actually. This baby will get more complete and actually can do it. So prediction of CPAP, predictions of extubation, till now we don't have enough evidence to support using it. For us actually, for people who use the Drager, the best and most important mode to know if your baby is going to succeed or not is BCV. If you shift your baby to BCV and you put him back up rate 15, and you see your baby is maintaining his blood gas for 4 hours, maintaining his oxygenation for about 4 hours, this baby is wonderful and there is no apnea and bradycardia. This baby is wonderful and is candidate for extubation. So for Drager's BCV, I think is the best method to know if to tell you if this baby is going to fail or succeed extubation. No, it's not my, as I said, I take from Stephen Duff, and he has very nice paper, I recommend everyone to read it. I think this is the only paper about weaning immunity from mechanical ventilations. It's published in 2 weeks. He said, exactly, and this is not evidence-based medicine again, like this is the last level of evidence, anecdotal. So it's just like self-experience. If you like to implement it, if you don't like it, it's okay. He said, we have encountered our baby who failed extubation many times, we increase the hemoglobin to. This is his idea, just in case we have baby, you try to extubate it many times and he failed, you can give him blood transfusions and it's can improve. But remember also, blood transfusion didn't help us in apnea prematurely. The study didn't. So this is their experience. That's why I put his name, I put the reference of the paper. If you'd like to go back and read the paper. It's not like there is no randomized control trial done for it. There is no meta-analysis. So it's not level A, not level B. It's just like some sort of control experience. Yes?
عايزة أشكر حضرتك الأول على البرزنتيشن الكتب الجميلة وعيشتنا في كأننا يعني جوه بس أنا ليا سؤال إحنا ولا دي في الكيسز بس اللي إحنا بنعمل ديسيجن على 1 بلاد جاز ولا 2 بلاد جازز ما بينهم مثلا نص ساعة عشان نقدر نستبيل بتاع البيشن يعني إحنا هنا عشان التعليم بنعمل ديسيجن على 1 ريليز هل في الكلينيكال؟
No, I mean, I agree with you. It's like, you see, like the first scenario, it was 3 hours old baby. So actually he has just blood gas and in practice we cannot stop our nurse to do it. Like immediately they insert it in certain IV, they take, they take even venous blood gas. We don't believe too much in venous blood gas. That's what we are doing. But first time we put the umbilical arterial tester immediately after we put, we take our blood gas. So mostly we have initial blood gas. But after 3 hours, you see your oxygen requirement for this baby is increased. Your PCO2 actually went up higher, and at the same time, when they did X-ray, they found that they get bad arteries. So here, for this scenario, you don't need. But for a chronic baby, BBD definitely trend is very important. As the Demerdage just updated them, blood gas don't be interpreted as once, should be at least you have 10. Your baby, this is his acceptable CO2, 60 or 65. If this CO2 second day becomes 70, then there is some problems. If this baby have always CO2 70 and then second day CO2 came to 65, then this baby improved. And so the baby was yesterday 55 and today 65 is worse. No, the trend is very important. I agree with you. But just like the main idea, that's why we put this scenario. The main idea, if you have acceptable blood gas, this is the trick of it. If you get only this message from this presentation, it will be wonderful. If you have acceptable blood gases, please move. Don't stay. Just don't stay. If you have gases with an acceptable parameter, 7.25, you have CO2 60, and your acceptable range is 65, 55 to 65. Don't wait and say, it's okay, it's good gas, I will wait till the baby wants CO2. No, this is the idea, and that's why the team who accept, and that's why actually I put it as quiz actually. Here, that's why they change, because this is their idea, this is our guideline, this is our protocol. So what I will do if I have CO2 50? So what I will do, like this is their stuff, they say. They said, for their stuff, I have this gas, I have very good gas, 7.25, I have CO2 50. What I will do? Yeah, this is the point. They learn the residence, they learn the respiratory therapy, they learn their team. If you have this gas in this range, move to next system. So this is the idea. So that's why they succeed. But if they stay on the same, like this is acceptable gas, I will repeat after 6 hours, okay, this is acceptable gas, I will repeat second day morning, then you will maybe stay on the mechanical ventilation with more injury and actually will go in vicious cycles of injury. So this is the idea of it. Have one acceptable gas, please move.
شكرا حضرتك جدا يعني this wonderful presentation. احنا زي ما قلت نسلة نعمل بريك شورت برزنتيشن على ما البريك بتاعنا